Welcome to the orthoPAC, where we discuss up-to-date orthopedic topics for the busy clinician. I invite you to sit back and relax as I attempt to fill in the gaps between education, current events, and real-world practice.
Hello everybody, my name is Dowell, physician assistant working in orthopedics, primarily urgent care orthopedics. Thank you for joining us for another case presentation today. Going to do something slightly different today. I saw a patient in clinic. He was a 16-year-old gentleman complaining of increased pain within the left shoulder. Most of his pain was in the left kind of parascapular area. He states he was doing a jiu-jitsu tournament. He didn't have a significant injury to the arm, but the arm was twisted, not necessarily an arm bar, but was twisted. He did have some increasing pain after this time, was able to continue to finish the match, but has had ongoing symptoms since this time. He was able to maintain full range of motion within the shoulder area. He was able to participate in most of his generalized activities, but whenever he went back to jiu-jitsu, did a lot of upper body strengthening activities, he noticed increased pain within this posterior scapular area that radiated to the posterior shoulder area and caused some increased pain with activities above his shoulder level. On examination, I think this is the most interesting part, and I will segue here a little bit. When I do examinations of my patients, especially that come in with shoulder injuries, I think there's two different types of examinations we can do. If somebody comes in with acute fall or trauma and they have decreased range of motion, significant pain, they're holding their arm into kind of the splinted position, these are more concerning for soft tissue injuries, rotator cuff injuries, fractures, whatever it may be. Oftentimes my examination will be pretty limited in these patients as I don't gain much from putting them through a lot of special tests. I'll check range of motion, active and passive. I'll check strength. I'll do a good palpation around the area, and then we'll get some x-rays to see what they show and then, discuss what to do from there. I think with these acute injuries, with these restricted range of motion or kind of, protected arm positions, the palpation and the mechanism of injury is probably the most important part. When patients come in and they complain about more of this chronic type pain within the shoulder area that's been ongoing for a long period of time, but maybe exacerbated recently, these are the patients I'll tend to do more of a functional examination on because I think oftentimes this functional examination will show me quite a bit. So in this patient, interestingly enough, his examination, if you looked at him holding his shoulders into a resting position, so I just have him sit and have both arms on their laps. Normally the dominant arm is going to be slightly lower sitting than the non-dominant arm because typically that dominant arm is what they use to do most of their activities. The soft tissue is slightly more stretched out, which is going to create that side to sit a bit lower. Oftentimes the non-dominant arm will sit a bit higher. In this patient, his non-dominant arm actually sat a bit lower than the dominant arm. If you looked at him, you could see that the trapezius on his non-dominant side, the left side, was overdeveloped compared to the dominant side, which again was a little bit peculiar in this patient because why would his trapezius within the non-dominant side be overdeveloped if his dominant side was the side that he would use to do most of his activities? And then I'll put them through a range of motion. So I'll have them forward flex and abduct and look to see if there's any compensations or changes to their shoulder movement. And for this patient, he did significant shoulder hiking. So when I asked him to abduct or forward flex, the first thing he would do was he would shoulder shrug using that trapezius muscle to bring the shoulder up. And then he would kind of try to get the rest of the range of motion after the shoulder shrug through some deltoid type activity. So again, I think he has some compensatory pain within this area, whether this is secondary to an underlying soft tissue injury or this is just some imbalance, neuromotor loss of control that he has within the area, remains to be seen. And then I'll test strength. So I'll check the rotator cuff strength with a lot of these activities. And then, you can go into special test after this, checking for anterior posterior instability, drop arm test, speeds, Jurgensen's type testing if necessary. For these young patients and oftentimes older athletic patients that come in with this chronic pain, I'll look from the back as well, which I think tells me quite a bit with these functional evaluations looking for soft tissue imbalances or injuries. And so for this patient, when I look for the back and I had him stand up, and I'll have him take the shirt off if possible, he had significant overdevelopment of that upper trapezius on the left side, as well as his rhomboids and parascapular musculature on the left side compared to the right. So again, a bit peculiar on this patient, especially this being his non-dominant arm. And when I had him forward flex, he did this shoulder shrug activity again to compensate for this initial kind of activation of the forward flexion activities. But you could also see significant winging and scapular dyskinesis in the area that was exacerbated when I had him lower his shoulders down in both the forward flexed and abducted position. So for this patient, he obviously had significant scapular dyskinesis, loss of neuromotor control, neuromuscular control within this area. Now, Oftentimes, this is hard to decipher whether this came first and this is a compensation secondary to underlying soft tissue injury, or the injury that he sustained potentially is causing this. Now, we do see, scapular dyskinesis or scapular winging and long thoracic nerve palsy, which is always a possibility, but this patient didn't necessarily have that because he didn't have the winging in a standing position, just a normal, resting, comfortable position for him when I just had him stand, have both arms down by his side. I'll often put my hand on the scapulothoracic area. I'll feel to see if there's any crepitus within the area. They can have this snapping scapular syndrome, or they can have a bursitis within this scapulothoracic bursa that can often cause increasing crepitus within this area. And one of the things I've learned from one of my mentors previously is to try to have the patient do these activities with stabilizing the scapula to see if this reduces his symptoms. So what I'll do is I'll put one hand underneath his arm on kind of the front of his waist area, and I'll put my second hand onto his scapula, holding that scapula down, and I'll ask him to forward flex and abduct his arm again. And for this patient, I had him do this, and he was able to do this with relatively pain-free range of motion. So again, this showed me that if I stabilize the scapula into a normal position, and I don't allow this dyskinesis or abnormal arrhythmic motion of the scapula, his symptoms did improve. So again, for me, this helps to tell me that most of this patient's pain is coming from this abnormal motion of a scapula, and potentially if we can get him into some physical therapy, learn some better control of this scapulothoracic joint, reduce the scapular dyskinesis, more neuromuscular control of this area, oftentimes this can alleviate his symptoms. Now, this is a difficult thing for patients to have treated because the physical therapy does not work quickly on this. It can take 6-8 weeks, if not sometimes 3 months to allow this to completely resolve, and does require a lot of work by the patient to get these symptoms to improve. So I think it's important to educate these patients that oftentimes we can correct this. This is typically not an underlying structural problem. We could obtain an MRI on this patient, but likely it's going to come back negative, and they're going to need physical therapy to correct these soft tissue imbalances that they have. Again, I think these functional evaluations, which I've learned to do a lot in clinic, especially in these more athletic patients that come in with this chronic type pain, this pain that's induced or created by more sports-specific activities, can oftentimes give them feedback or show them visual abnormalities where it's like you can see the soft tissue imbalance that's potentially creating the problem. So for this patient, I was able to get his parents to stand behind me, and they can see the scapular winging. They can see the asymmetry as far as his muscle development on the examination. And when I explain my thought process behind this being his non-dominant arm with this overdevelopment of this area, this is not something that's happened recently. This is something that's been going on chronically to cause this overdevelopment. They can often, buy into getting physical therapy for this patient and treating this conservatively. Now, again, if this patient goes through physical therapy for 3, 4, 6 weeks and does not notice some symptomatic improvement, again, this won't cause resolution of his symptoms, but it should cause some symptomatic improvement. If he goes through therapy for this period of time and does not notice 30, 40, 50, 60% improvement of his symptoms, MRI may be necessary at that time just to make sure we're not seeing any structural abnormalities within the shoulder or the scapula area that could be contributing to his symptoms that may not benefit or improve with physical therapy. Because occasionally we will see evidence of this snapping scapular syndrome. I've seen osteochondromas within the scapulothoracic area that can cause a big bursitis or fluid collection and pain. I've heard of soft tissue tumors within this area causing symptoms as well. So therapy can take a long time to improve, but if they're not noticing some level of functional improvement, the MRI may be necessary to make sure that there's no underlying problems that wouldn't continue to improve with the therapy activities. When ordering MRIs for these patients, I will say that shoulder MRIs do not typically pick up the scapulothoracic joint, and you have to order a scapular MRI by itself. If you are part of an orthopedic practice, oftentimes I'll call my radiologist or my MRI techs and ask them, hey, I'm trying to evaluate the scapulothoracic joint area. What do you want me to do on an MRI? Do you want me to order MRI and say this is what I'm evaluating? You can open up the field to encompass this area. Or do you want me to just order an isolated MRI of the scapula just to make sure that there's not something specifically going on with this area? So a little bit different of a case presentation, but with my athletic training background, I often find myself doing these functional evaluations in these patients that come in with more of this chronic exercise-induced type pain, because oftentimes these soft tissue imbalances, mobility issues will be what causes these things. So if somebody comes in complaining of knee pain with activity, hip pain with activity, lower back pain with activity, having them do a functional evaluation. And what I mean by that is checking the range of motion of their hips, seeing if there's an internal external rotation deficit one side compared to the other, having them do a double leg squat activity, seeing if they're shifting their hips one way versus the other, having them do a single leg squat activity with assistance holding onto the table, seeing if there's significant knee valgus or Trendelenburg causing gluteal weakness. Again, checking, functionally with range of motion activities with the upper extremities, looking from behind, evaluating the scapula from behind will help you to evaluate for these soft tissue imbalances. This could be a patient that might have seen somebody in clinic, not done more of this functional evaluation, gotten an MRI came back negative, told him it'd get better with time, and he could have had a prolonged course before, finding these scapular dyskinesis or muscular control imbalances that potentially could be corrected in a more timely manner. So I definitely would encourage you to try and or think about these functional evaluations in these patients that come in with more of this chronic type complaints. Again, I don't do these in patients that come in with acute complaints. If you immediately bent over and hurt your back, had an injury that hurt your knee, hip, shoulder, whatever it may be, these evaluations are definitely not the case in these groups. But if it's more of an onset that's prolonged onset or more of a exercise-related pain, I think these evaluations can often show you soft tissue things that can typically lead you down the road to finding the cause of the problem. So again, thank you for listening to this case presentation. I hope you enjoyed this. Please feel free to reach out regarding any topics you'd like to see covered in the future.
This is Sam Dyer from the orthoPAC. Looking forward to a discussion on when can I return to sports after my injury or orthopedic condition. I wish you all a safe and happy holiday season and a prosperous new year.